Good evening. This fall, Massachusetts voters will likely weigh in on what's being called the Death with Dignity Act, which would allow terminally ill patients to take their own lives. As debate over the proposal heats up, one Reading woman has a unique perspective. Heather Klish's father was treated for cancer in Massachusetts, but died in Oregon, where he ended his life using a similar law. WGBH's Adam Riley has more.
Lee and Mary Lou Johnson were on their way from Oregon to Europe for a cruise down the Danube when they stopped here in Boston to visit their daughter and her family. Right away, Heather Klish knew that her father wasn't well.
He was kind of strangely foggy. He was falling out of chairs. He would sit down in a chair and miss it. He would go upstairs when he went to go downstairs. So something was telling us this is very wrong.
Johnson went to the emergency room at Mass General, where he was diagnosed with glioblastoma, the same kind of brain cancer that killed Ted Kennedy. But Johnson's prognosis may have been even worse.
His crossed both hemispheres of his brain, and the doctors were very consistent in telling us this is inoperable.
Johnson was treated with radiation and chemotherapy, but he was already planning his next move.
We were in the hospital, and he first did say, well, we've got to get back to Oregon, so I have access to this Oregon option.
The Oregon option is that state's Death with Dignity Act. It allows adults who've been diagnosed with a terminal illness to get medication that they can use to end their life. Johnson returned to Oregon in late December.
He knew he wanted to go about dying with grace. How would he treat people? How would he spend his time? And interwoven with all of that was trying to figure out for himself what was that line? What was living and dying with dignity?
When her father's condition worsened, Klish flew out to be with him. The next day, he announced he was ready to die.
He took the drink of water and he laid back and he said, okay, I'm ready to go. And I said, Dad, no, that wasn't that drink. And he said, well, it's time to get that drink.
After triple checking his intentions, Johnson's family contacted the end-of-life group Compassion and Choices. A volunteer came to the house and prepared a lethal dose of the drug Seconal, while Johnson and his family said goodbye.
We sat in the den where the bed was and just talked. And it was actually strangely nice. He was funny even at the end, and his last thing that he wanted to eat was a piece of toast with raspberry jam, because he loved raspberry jam, and he just completely enjoyed it.
Then, a few minutes later, Johnson reached for the cup.
He took the drink in his hands and drank it. It was very fast. Then he, I would say within minutes, appeared to have fallen asleep, but what happens is that he slips into a coma. And I would say it was about 10 or 15 minutes until he died, until his pulse stopped. And the volunteer was very discreet. She was in another room, and she was the one who came and checked his pulse and told us when he had gone. It was very peaceful.
Critics argue that for the terminally ill, hospice care is enough. And Heather Klish admits that end-of-life suicide isn't right for everybody.
But for someone like my dad, it was right. And someone for like my mom. I mean, my mom, when he died, my mom was in his arms. Her one hope was that when he died, he would know who she was and know that she loved him. And so it was planned. It was planned, and it worked out that way.
All right, and with me now are Dr. Marcia Angell of Harvard Medical School, who supports the Death with Dignity Act, and Dr. Barbara Rocket of the group Physicians Against Suicide. Welcome to both of you.
Thank you.
Well, there's no question that was a very emotional case, and it worked out for them, and there are many, many other cases where it may not be right. But when you were listening to that particular case, Barbara, was there anything about it that made you feel uncomfortable?
First of all, it is not death with dignity. It's asking a physician whose primary role is to heal a patient, to aggressively address the needs of the patient at the end-of-life care, and that sort of thing is not what physician-assisted suicide is.
Well, this is really physician-assisted. The patient has to do it him or herself.
The physician has to prescribe medication within 2 weeks. We don't know if that patient ever receives the medication because it could be diverted to someone else. And when the patient takes that medication, I have heard of one patient who went into coma, came out of coma, and then a physician had to intervene and come in. Not the patient's physician, but another physician who was asked to give medication.
A lot of old people die deaths that are far from dignified, even in hospice. Agree?
These patients have to receive care and support. Many of them are very depressed. If they are depressed, they should be given psychiatric care. We have hospice, we have palliative care. These things are available. We should make them comfortable, and if it requires medication to keep them comfortable, if there is an adverse event as a result of it, it's not that the physician has actively participated in a suicide.
That is the key. Although, having been through this recently myself, I don't know if there's anything, maybe you would disagree with me too, about giving somebody a drug if they're in a terminal state for depression. That seems, you know, like, you know, of course you're depressed, you're going to die. But the arguments against it that you're listening to Barbara say, I mean, the HIPAA codes, you know more about it than I do, say first do no harm. So why would you want to actively participate in ending, that's the ultimate harm that you can commit to someone?
No, it is not the ultimate harm. This is not a matter of choosing death over life. By definition, these people are irreversibly and terminally ill. They will die within 6 months, whatever treatment you give them. So this is just giving them the choice, given that situation, of controlling the manner of their death and of choosing, if they want, to have a slightly earlier and much easier death. That's what this is about, a choice. I agree that palliative care is successful most of the time, but this is for individuals who find that it isn't. And what's interesting in Oregon is that almost all of the roughly 600 patients who have availed themselves of this law in the last 14 years have been receiving hospice care, have been receiving very good palliative care. But for a few people, that's not enough.
We should also say there are parameters, and you know them better than I, but you have to ask for the drug twice within a 15-day period.
Once in
you have
writing.
to be compos mentis. You have to be able to make the decision yourself. It can't be your daughter or somebody else making that decision for you. You have to be an adult.
And you have to swallow. You have to swallow the medication.
You have to be able to swallow, and you have to be diagnosed with something that's going to kill you, although no one can ever be certain of that, within 6 months.
Yeah, I can't see why anyone would have an interest in requiring desperately suffering people who want an early release. Why would anyone want to prevent them?
Doesn't this, in a sense, go on in medical institutions in another way? It may not be a lethal cocktail, but it's the amping up of morphine and other things at end of life. So it's not. It's physician assisted in a sense. You know, the family can say, well, I think my husband is suffering, and so there are ways to do it. It just doesn't have maybe a legal bill attached to it, but it happens.
I don't feel physicians should be mandated to do something like this. It's against most physicians.
But wait, they're not mandated.
No,
they wouldn't be mandated. It would be their choice. So.
It would be a legislation, a bill that would
But a doctor wouldn't have to participate.
No, and in fact, in Oregon, most requests are denied.
Yeah.
Most of the time, doctors deny.
So you wouldn't have to participate, but another physician who was agreed to it would.
The majority of physicians in the Mass Medical Society have voted against this, as well as the American Medical Association. California had an overwhelming response against the bill, saying it was a bad bill, it was bad ethics, and it was bad medicine. And I agree with that, because I feel that physicians are there to help. You describe a situation where morphine might be ramped up. Yes, that's so, in order to keep the patient comfortable. And as I said, if death occurs as a result of it, this is not an action that is actively trying to kill the patient, but make the patient more comfortable.
It is true that the American Medical Association opposes it, and the Mass Medical Society opposes it, but the American Medical Women's Association supports it. The American Medical Students Association supports it. And at the time the Oregon Death with Dignity Act was passed, the Oregon Medical Association took no stand, either in support of it or against it. Well, so doctors are not all the same.
Okay, well, one of the big concerns, and I'm sure Barbara has this too, is that it's a way of like clearing out the unwanted. All these people sitting around nursing homes, it's like they're gonna, well, I mean, that's one of the arguments. Or that sons and daughters or other relatives might also get in on the act because it would speed up their inheritances. I'm just saying that these are some of the things that are that cloud the issue.
But the safeguards address this. There are all kinds of safeguards that would really make it impossible for that to happen. And if you look at the, as I said, roughly 600 people in Oregon who have used this law in the last 14 years, most of them are well-educated, white men, well-insured, with hospice care. There is, if anything, fewer vulnerable people than you would expect in the population.
Barbara, do you have any of those concerns?
This could be a slippery slope. We know at the end of life, that's the highest cost in medical care. And if this is known, it could easily be a cost saving by having these people commit suicide. And that's something that is unacceptable as far as the medical profession is concerned. We're there to assist them. We're not trying to save money for the government.
Is there a religious component to this?
Oh, of course. Many of the religions oppose this. And, but beyond that, I think we have to consider what the physicians feel most of all. And
well, what about what the people want? Forget the physicians. What about the patients?
Well, you know, let me tell you, I was at a grocery store, and I went up to a stand that said Death with Dignity, and I said to the person, this really isn't death with dignity, you're fostering physician-assisted suicide. And he said, lady, don't tell me anything about it, I'm just getting money for every signature that I collect. That's fraudulent.
Well, a lot of candidates do that too. You've got 86,000 signatures, that doesn't necessarily, the legislature has to vote on this by May 1st, they won't, let's face it, I'm just telling you right now, that's not going to happen. And then you have to get 12,000 or more signatures, so it could end up on the ballot by November, but there's no guarantee that the legislature is going to push this through.
You know, I am less concerned with what doctors want than with what patients want. I think sometimes doctors have a too narrow idea of their own obligations. They feel that it's their obligation to extend life, even if, by definition, it can't be extended significantly. And if you have that situation, then it seems to me they have two obligations. One is to support the autonomy, the self-determination of their patients, and the other is to relieve suffering. If you can't extend life significantly, then you must relieve suffering.
Right. Barbara Rocket and Marcia Angell, thanks so much for coming tonight.
My pleasure.
Thank you so much.